So this segment will be about the knee, finishing with tibial external rotation, extension of the knee, as well as patella mobilizations. Continuing on with tibial rotation, we're going to focus on tibial external rotation combined with knee extension because they are two motions that occur simultaneously. When you're talking about this joint by joint philosophy, the most common loss of range of motion at the knee is knee extension. So as a quick review, we have a ligament joint, a cuff joint, ligament joint, cuff joint. This now becomes a ligament joint. A quick way to remember that this is a ligament joint is thinking about an athlete in defensive position. If an athlete is in defensive position, they're living on their muscles when you talk about maybe a mechanism of injury that they got hit, or if you're talking about maybe a soccer player or a football player where they go to step, rotate, and take off, they are using range of motion at hips that are being controlled by a rotator cuff. So this ligamentous joint at the knee would be considered safe because it's being protected by these large muscle groups and these large rotator cuffs above and below the knee. If you are talking about a player who is not in defensive position, now they're living on the ligamentous structures of the knee and they're more at risk of being torn with a mechanism. So if you're talking about an athlete who is standing tall and they go to cut and turn, now they're living on those ligaments rather than the rotator cuffs above and below, and they're more at risk of things like an ACL tear or a meniscus tear. So knee extension is one thing that we really want to make sure that they have full knee extension because they already have a great range of motion into flexion. If you're talking about post-operative ACL reconstruction or even a meniscus repair, or even if they went in and trimmed out the meniscus, the biggest range of motion loss is going to be knee extension, whether it's coming from the screw home mechanism or from the patella. So by blocking this knee and maxing out her extension, she has about 10 degrees of extension. See how high her heel comes up off the table? Maybe even more than 10 degrees. She's not a person that would need extension mobilizations, but we're going to show you how to do them regardless. So we're going to actually bump her up a little bit. This is not going to be a very good mechanically position for a practitioner because I want you to be able to see what I'm doing. On this leg, I will set it up more mechanically sound for the practitioner. You're going to use that same horseshoe position at the top of the tibia. If you're not familiar with how to find the joint range of motion or the joint line, bend the knee and feel for this little valley between the tibia and the femur. It has a very defined plateau that you can get your hand on. You want your mobilizing hand as close to that joint line without being on the joint line. You're going to be on the tibial side. Your other hand is going to be on the femur, and this is going to be your stabilizing hand. Your mobilizing hand is actually going to rotate the tibia into external rotation while you apply a posterior force. So if we're talking about that concave convex idea again, this would be the femur, this would be the tibia. We are disimpacting with our hand. We're also applying an external rotation and an anterior to posterior force, driving that tibia, stepping it off from the femur. So this would be a stabilizing, we're disimpacting, we're rotating, now we're going to drive it straight posterior down into the table. Again, my mechanical position is not a good one, I just want you to be able to see my hand position. Going over here to the other side. Remember, using your body weight is key. We're not using our own strength and tearing up our joints for the sake of our client. So we're finding that joint line, and I'm just below it on the tibial plateau. I have my big horseshoe. I'm going to stabilize her femur. I'm going to load directly over my hand. My wrist is in a safe position because it's in a more extended neutral position. My elbow is nearly locked out, and I'm going to load into my shoulder with my body weight. So I'm disimpacting, I'm externally rotating. Now I'm going to load the joint into extension. There's a couple ways that you could set it up in the clinic. If you feel like you're not getting a good range of motion, you could step off the femur and the tibia so that they're both elevated off the table. She would need a bigger bolster here, but it's the same concept. You're stabilizing the femur. You disimpact the tibia. You externally rotate the tibia, then drive it anterior to posterior at a grade 4. You can do grade 3s, but they're not going to be very comfortable. Go to in range and stay at in range. The next piece is patella range of motion. The patella is really key, as this is a fulcrum for your big quadricep muscle in producing force. Somebody could live without a patella, but they're not going to be able to produce as much force at the knee. There are all kinds of dysfunctions that you could see with a knee, like a frog-eyed patella, a winking patella. We're not necessarily going to go over those, but just know that this is a key joint when you're talking about knee health, especially when you're talking post-operatively. If there's a reconstruction done at the knee, if there was a scope at the knee, these patella mobilizations need to be done for 6 months post-operatively every single day, and teaching the client how to do them is going to be a great piece for homework for them and keeping their knee health and avoiding patellofemoral syndrome or patella tendonitis down the road. For her, because she has so much hypermobility into knee extension, I'm actually going to take her there for these. And now her kneecap is really loosey-goosey as compared to here, where she doesn't have as much mobility. You need to be able to move the patella in multiple planes. So we're talking about medial, lateral, superior, inferior, and working at angles, and also tilting the patella and rocking the patella. If you're talking post-operatively, this is going to feel really good for them. And all I'm doing is pulsing my finger, moving that patella back and forth. You can move it up and down. You can tilt the patella by going onto the inferior pole, the superior pole. You can rock it at angles. You can also bend the knee. This would be great for superior patellar tendonitis rather than inferior patella tendonitis. Again, we're watching this arch, making sure that we're in a neutral position. You're going to use the heel of your hand. You're going to load the top of that patella straight down. Again, I'm using my body weight rocking down. I'm not using my shoulder force. I'm using my body weight to rock into the mobilization. If you have a large silicone cup, you can use that as a patella plunger. You could also use a sink plunger. You put it literally right on top of that kneecap, and you can mobilize it by using the cup as a handle rather than using your fingers. That would also be an option. Going over here, we'll show the same thing. So my thumbs would be on this lateral edge, loading that patella, or my index fingers pulling it, popping it with the inferior pole or the superior pole, rocking it left versus right, and doing this mobilization from the top using the heel of your hand. And again, you're using your body weight to rock that patella straight inferior. And you have to follow any mobilization with some sort of re-education that's in weight bearing for the brain to recognize the new available range of motion. Again, the most simple would be a body weight squat. You could have them do a resisted knee extension off the table. That would be an open chain resisted exercise, and that would be okay.